over prior ER, and he's going to lecture you on the 7 deadly chest pains. I'll turn it over.
So my lecture's a little bit, well, I like to think a little bit different. You probably won't think they are. But if anything, I just want you guys to be able to pay attention. I usually bring cards. I don't know if you've heard of that or not, but like playing cards. And I usually hand them out, and then I pull them out randomly for questions. And you're thinking, why? So, because my wife is a PA, and she's gone through all this, and I know that there are people that come and give lectures that completely waste your time, I guess you could say. They come and give lectures that have no importance to what you're doing now, and you don't think you're going to do oncology, so it's not really going to be on a test in the board. But this will be something like we'll go over, and I'll talk about other things, and if you have questions, just stop and ask me. All I ask is you just pay attention. I know it's kind of a lot of stuff, and I apologize for being late, but it'll be quick, and you have the slides, but I'll try to explain things so you can understand them, not merely just try to memorize stuff, because if you don't understand something, you're not going to remember it. I don't know when I went to med school, they said if you can remember 10% of what you learn in med school, you're doing well, and that would be doing well, because I don't think I remember 10%. The amount of BS they make you go through, it's just unbelievable. So you need to understand things in a way where you can remember them, because if you don't use them, then you will forget. So when things make sense, you can kind of remember and figure out in your mind. So no matter what you do, you need to understand some of this stuff. If you feel like I'm never going to do ER, I don't care, that's fine, but I can tell you, you need to understand who is sick, who's not sick, and you may want to do ER, you may want to do primary care, but I guarantee someone's going to walk through your doors that are sick, and if you don't understand who is and who isn't, you will maybe miss it. So all these things are important, believe it or not. So, all right. So our objectives: define acute chest pain, initial approach to all patients, identify 7 deadly causes, treatment for each diagnosis. So, all right, chest pain. So the sudden or recent onset, area from the xiphoid to the suprasternal notch. So basically we've got like the box of death, right? So anything below the neck, between the shoulders, above the mid-abdomen technically, is anything that's going to be changed in there you got to be worried about. Because, you know, people are weird. They don't follow all the rules. Your board questions of, you know, stabbing, pain, radius to the back, tearing, all that stuff, you don't see that all the time. Classically, sometimes you do, but you have to have a real wide net of what could be going on to try to spread out your diagnosis. Noxious or uncomfortable sensation, sure. Okay, so you got somatic out visceral. Now this is the part that gets a lot of people because, you know, you got somatic chest pain and visceral chest pain. Easily described, precise, located. So, and I always try to explain this to a way where I explain it to the patient. So I walk in and the patient is like, oh, I got a little bit of arm pain, or I got a little bit of belly pain. I say, well, this could be your heart. And they look at you funny, and you're like, well, let me explain something. You've got 2 different nerve systems in the body. You've got mapped and non-mapped. Mapped is the skin. You close your eyes, I touch your knee, you know I'm touching your knee because it's mapped in your brain. But your organs are not mapped. So what they have to do is they have to refer pain to the closest mapped site. That's why you get arm pain when you have a heart attack, because it refers to your arm. I mean, you guys are like, yeah, duh, we know this. But that's just something like, it's kind of hard because it mixes everything up and muddies all the water, because you can't count on some of those things to help you to know, oh, well, it's just pain on the right side. And they've done so many studies to try to say, oh, well, pain on the right side, that's safer than pain on the left side. And all these studies have been inconclusive, and it's not true. So your initial approach, you know, are ABCs, and then you've got all these mnemonics for doing stuff. But basically, depending on where you're at and what level of resources you have is going to dictate what you can do. Sure, if you've got oxygen, cardiac monitor, IV, but you know, if you don't have those sorts of things, what are you going to do? You have very limited resources. Use what resources you have. So if you have all these things, you want to put them on a monitor. And none of these are necessarily important from an order of operations. You know, a patient rolls into me and they're not breathing. You kind of start at the beginning, but you want to have one nurse putting them on a monitor. You know, is their heart really beating or not? What's their stats? What's, you know, what else is going on? So it's, you know, it's good to know all these things because it'll help you with your boards. But in reality, if you're working in some place, whatever resources you've got, that'll help kind of figure out what you can do. So initial approach: obtain and interpret EKG within 10 minutes all around. Well, that's actually kind of like the recommendations or requirements now, pretty much. Anything that's chest pain or symptoms concerning for acute coronary syndrome. So what we talk about now is there's chest pain and there's chest pain equivalent. So shortness of breath, arm pain, dyspnea on exertion, dizziness. All these are considered chest pain equivalents because realistically it could be MI. And that's what we get to, or any kind of cardiac effect. So And take a good history, sure. I mean, in the end, if you do all these tests and stuff, you don't know what's going on, the smartest doctors and PAs in the world will tell you that the history has all the answers if you know how to ask the right questions. So acute MI, this is pretty straightforward. Everybody has plaque, and over time it builds up, and then the theory is maybe a piece of plaque breaks off, or a thrombus of somehow goes from somewhere downstream, goes up, gets caught in the artery, and they have an acute occlusion. Whereas opposed to like angina is that slow progression, like exertional stuff, because as it starts to narrow down, you only have a certain amount of flow. So if you exceed what you can keep up with, then that's when you get your symptoms. So with angina, it's like they get up, do something, they go, oh, I kind of short of breath, kind of chest pain, they sit down, they feel better, and they get up, they do it again, and they get, same thing over and over. If they can rest and it gets better, that's more angina, that's more narrowing, that's short. But of acute onset, ischemic change, that's more like an MI type thing. So the classic diagnosis is going to be 1 millimeter ST elevation and contiguous limb leads, because they're less sensitive. 2 millimeters ST elevation and contiguous precordial leads. And it says both in the presence of chest pain or symptoms. I can't tell you how wrong that is. I mean, that's the standard thing you know for boards, but like, I can't tell you how many little old ladies that come in and go, yeah, I'm just here because I just feel a little tired. You're like, okay, grandma's tired. Did you take your thyroid medicine? Oh, okay, you do an EKG. She's got massive tombstones on her EKG with ST elevations. And her troponin 6.0 because she had an MI yesterday. You know, it's crazy. So, chest pain, you just have to kind of grain of salt. If they look like they've got some risk factors, or just anything can be a heart attack. It's kind of scary these days, but you just can't rely on the patient to tell you, oh, I'm short of breath, I'm having chest pain. So some people have zero symptoms whatsoever, but they will have changes on the EKG or the troponin. So treatment, same thing we talked about before: oxygen, aspirin. You have a beta blocker, with or without nitro. So these different things, you put them on oxygen because the thought process here is it's going to offload some of the stress to the heart. Okay. Second thing is aspirin. It'll break up any small clot that could have occurred recently, and you're not going to cause them big problems. So if they have like something else besides an MI, like a big dissection or something, aspirin is not going to put them in terrible peril, as opposed to giving them like a big, shot of Lovenox or something. So aspirin, you got beta blocker. Beta blocker theory is it's going to slow down their heart rate, because when the heart has stress, you're going to get tachycardia, right? And so with that stress, you're going to have a higher heart rate, and a higher heart rate will then drive the heart to beat faster and harder, and then it'll stress it even more. So given the beta blocker, it'll slow down the rate, slow down the pressure, make it easier on it. And so that's the blood pressure of choice by cardiology. Now the nitro, with or without, traditionally nitro is driven by two things. One is pain. If you give them aspirin and their pressure is high, I give nitro, because nitro will drop their pressure. Now the flip side of it is, if the pressure is really low, you got to look at the whole patient. Sometimes if their heart rate is really, really high, and they have typically over 140, they have a filling defect. So if you slow down their heart rate a little bit, then their blood pressure will come up. But most of the time, if you give them nitro, it's going to drop their pressure. And it's going to really drop it with a inferior MI, so you got to be careful with that one. But realistically, nitro, if the patient's still in pain, you give them some nitro if their blood pressure can afford it. Then you've got the anticoagulation and all these other inhibitors, and most of the time you're not going to deal with this unless you work in like a cath lab setting. But reperfusion, so PCI versus thrombolytics. PCI is going to be when anybody is close enough to get to a cath lab. Thrombolytics is you're out in the boonies, and they're not going to get to the cath lab within 90 minutes, so you're going to have to try to give them anticoagulation. So those are your options from that standpoint. So that's kind of a clear thing for some work out in the wilderness. All right, so with the helicopter though, most people can get somebody to a cath lab within a certain period of time. So on your MI, this is just going to be something you need to memorize for your boards. This is roughly kind of where your MI is going to be based on the ST changes. So your occlusion, the RCA will show changes in 2-3 AVF, which is your inferior wall, or LAD, which is the widowmaker. I'm sure you've all heard about that. So V1 through 6. And it makes sense from a standpoint of anatomy if you think about it. Like, I don't know how many of you guys have put on an EKG or done EKGs. Have you guys done any of that kind of stuff? Okay. So you'll know how it's like V1, 2, 3, 4, 5, 6 kind of a thing. So if you think about it, that's what any problems with those areas of electricity are going to be kind of like related to that side of the heart. All right, so based on that previous map, where would you say the MI is on this one? And I really feel bad, I have all my cards, I've been probably asked 3 questions by now, so I'm kind of, so how can we do that? So you got ST depressions, right? And V2, V5, so it's kind of it's a funny EKG, but the clearest ones are going to be in your 2-3 AVF. 2-3 AVF, because you've got reciprocal changes over here like V5, V6. So, going back to your previous one, so 2-3 AVF of inferior wall, right? So, anyway, but this is not EKG class, I know you guys get tortured on that. All right, so dissection. This is one that, if you miss it, your insurance company just cuts them a check. So, a violation of the intima that allows blood to dissect between the intimal and adventitial layers. It's like the de-onioning of the large blood vessel in the center of your chest. And this can be sometimes painful, usually it's painful. Sometimes it can be painless, depending on how long it takes to happen. But most of the time, it's kind of chest pressure, shortness of breath. And I had a dissection last week on Tuesday from a guy that came in, and he had a significant dissection, ascending and descending. So yeah, he was 39. So yeah, it's kind of crazy. But so clinical suspicion: tearing, ripping, chest pain, radiating to the back, with or without neurological symptoms. The ones that get missed, I listen to a lot of different lectures on medical, legal stuff, and the ones that get missed with most of the time with dissection are the ones with the atypical chest pressure, sharp things, but they have the neurological deficits. And some of the neurological deficits can be crazy. They can be like stroke-like. Lots of people feel MRIs and CTs of the head, and the whole time they've had a dissection, and they don't stop to think about that. But it could be neurological symptoms in the legs. One guy was saying that he had leg weakness when he would have intercourse, but the rest of the time he was fine, and he had a big dissection down into his iliacs. It's crazy. So anytime you have like a weird neurological deal and chest pain, you've got to think dissection, because it affects all the nerves that way too. You also want to see it from a standpoint of, higher risk patients. So if you look at the pictures here, you can see the high risk. And every little old lady with a seatbelt sign is a dissection until proven otherwise, as far as I'm concerned. Because I've seen 3 in the last 6 months that were little ladies and caught their seatbelt, and it's just enough to tear. Because when people get old, they don't stretch, they tear. So that's kind of what happens. You have the pregnant lady there, the kid with the pretty significant seatbelt sign looks like. And then you got that picture down at the bottom. Anybody want to guess what that picture is trying to show you? There you go. All right. So, and the treatment initially is this blood pressure management. So, and it's beta blockers is typically what people always talk about, because it's that pulsatile impulse that you're trying to decrease, because they think it's that impact of the blood hitting with a high pressure that's separating those layers. So treating a beta blocker decreases that pulsatile pressure will help. So here's the different categories. The guy that I had last week was the baking one, actually. So he did all right. And this is all board stuff. People typically go Stanford A or B. B, believe it or not, is medication usually treated, depending on how high it is. But if it's dissecting down, they'll watch it with medicine, depending on how bad it gets. But a lot of these will treat with just meds. But everything else around the arch is usually surgically repaired. So, all right, tamponade. This one will get a lot of people because it's classic. So we'll talk about it. Increased fluid in the pericardial sac results in restrictive ventricular filling. So the intrapericardial pressures exceed normal filling pressures of the right heart. So the right heart is the low pressure side, right? And so if you can think about it, you got 2 sacs, and if the fluid around the heart increases in pressure, then the right side cannot open. It's a filling issue. So you can't open, take a breath, and push it out. So basically, that's where you're going to see more of your changes first. But the tamponade is classically done with trauma, anything with trauma. So classically stabbing, gunshot wound, those sorts of things, because you actually, trauma to the pericardial sac themselves. But I've seen, the last two I've seen were non-traumatic, and they were in young women. Anyone want to take a guess at what's going on with this lady over here on the far right? Huh? SLE, yeah. So anybody who has lupus or any kind of autoimmune illness, you have to basically add 40 years to their lives, because you have to look at them as she's 25, she's now 65. It's unbelievable. We had an 18-year-old girl had an MI the other day who had lupus. So lupus, we don't know why, but it makes everybody really old and really sick. And so it's just, the body doesn't work right, unfortunately. So always ask, with chest pain, some of my standard questions are always, if they're young, say, do you have a history of autoimmune illness? And I leave them off, like lupus or RA or ulcerative colitis even. I mean, weird stuff like that can happen. Crohn's, stuff like that. And if you don't, then family history of it, because that's something that can definitely increase the risk factors for things. So, diagnosis suspect based on history and clinical findings. Sure, JVD, hypotension, muffled heart sounds. Echo is the gold standard. Treatment, volume expansion. Yeah, you give more fluids, it can help, but the pericardiocentesis is the best option if you traditionally have some filling deficits. This is the EKG. It's kind of classic. I mean, you look at this would be very subtle, and so from a standpoint of understanding why EKGs do what they do. So the classic presentation of cardiac tamponade, and I'll tell you this and you can try to explain to me why, is that you get two changes that are pretty classic. The first is you get a decreased electrical picture. So the spikes are typically very shallow, or they're decreased, right? So here's your heart. Not an artist, but so you've got your electrodes right here, right? They're picking up the electricity. So you've got electricity running through this, and you guys have to take physics and stuff, like right-hand rule and all that stuff. It creates electric current and all that stuff. But basically, you're picking up the there's electromagnetic radiation, or whatever you want to call it, basically comes off of this, comes around off this. It's very subtle. That's what you're picking up here, okay? So what's going to change how much electricity is measured? There's two things that do this, and this will help you understand. When you look at EKG, you've got somebody with a huge QRS complex. You're like, oh my gosh. So basically it comes down to the signal. So the stronger the signal, the more your electricity is going to be picked up, right? So your QRS is going to be bigger when there's more electricity. But then what are the two reasons why there would be more electricity with some versus the other? How many are calling you guys? I feel bad on that. Huh? Hypertrophy. Hypertrophy is one, yes, because more muscle, more signal. What's the other one?
Fluid.
Huh?
Fluid?
Fluid. Well, on a regular non-sick patient, let's say you've got a EKG, they got big QRS. You're like, okay, so what's going on with that? So two things that may not necessarily be there, because your EKG is going to say, you have a big QRS, it's going to say, oh, left-sided, cardiomegaly or something like that. But they don't. So if they don't, then why is it reading it off? So it's two things. It's the strength of the signal and the distance. So you got a little old lady who's got a thin chest wall, and now your probe's right here. It's going to amplify it, right? So you have to take that into consideration. Look at the patient. If you got a big QRS, you're like, oh my gosh, they got a huge left-sided heart. Well, it may not be. If she's 100 pounds and she's thin as a rail, you put it right there over her heart, and you can get a big QRS. So keeping that in mind for tamponade, same thing. Tamponade is a big fluid sac around the heart, right? And then you got all this fluid in here. That's why when you put it on, you get very, very subtle EKG findings. So the spikes aren't very big. And the other thing, and if you look closely, it's kind of hard to see, but, okay, so look how this QRS right here is a little bit to here, and this one's deeper. And this one's shallow, and then kind of a little bit deeper, but then more shallow, and then deeper again. What do you think's going on with that? Why would that change?
Shifting stuff around.
Yeah, so you've got the muscle in here, and it's in a big sack of fluid. And as this thing is gonna be beating and twisting and turning, like it can kind of fluctuate and move back and forth. You're not gonna see that very much with other types of EKG changes, because they're almost all the same. So that's kind of like a little telltale on that. So if you see like a decreased QRS, and then of those QRSs, if they're just a subtle change in the amplitude of them, that could be tamponade.
Can you go back to that one? When we taught you guys EKGs, you were just getting the 12 leads. Notice down below, you've got the V1 lead goes all the way across, and same way with lead 2. When you're running a code and you're looking at the monitor, it's going to be on lead 2 that you're mainly looking at. That's how you can really pick up on the changes, is by looking at a long lead like that. You would be able to pick it up if you were really good at it, but it's going to be easier to look at the one long lead as far as like the tamponade that we talked.
Yeah, EKGs, your standard EKG is gonna have all of them across the top, and then usually on the bottom, you're gonna have lead 2 that goes all the way across. And so it's 6 seconds, so I mean, it's not very long to capture all of it. So, and all of them, and lead 2 is repeated. Like if you look here at lead 2 down here on the bottom, this first part is exactly the same as what's up here. So it's just, they give you a longer strip so that way you can march it out a little bit easier. Because there's just not enough room on the paper to put all 12 across all the way, so that's kind of how it's done. All right, so here's kind of a picture. You just basically see a big heart, which, you know, fine, that's what you would anticipate seeing, but you don't know if they've got CHF or cardiac tamponade. So then you've got on the, here's your echo, you got your myocardium, you got the fluid, and you got the pericardium, so you get to see the space. That's a pretty clear picture right there. So I think pretty much if that's on your board, you should probably be able to get that. All right, so going back here, tamponade, other things too. Viral illnesses can cause tamponade, particularly young women with lupus, with an illness of sorts, or just, I was working one time in Stillwater, and they called, I had 15 different people that were sick and waiting on labs, and the lab called out and said, you got a bump troponin of like 6 point something in room whatever. And I was anticipating it was the old man that was having chest pain. It was this young girl that came in with bad chest pain. She had a bad illness for several days. And so she had a bunch of fluid around her heart that was stressing her heart, and that's why her troponin was bumped. So you just, age is something we're learning is not nearly as protective from a cardiac standpoint. So perforation of the esophagus, this one's really weird. This one's kind of hard to miss. Usually you have a bunch of air. So clinical history, physical exam, subcutaneous emphysema. So it's like, they'll come and say, I got like Rice Krispies or something in my neck or my chin or something. It's really a weird deal. It's kind of not like a lot of other things. Whenever you've got subcutaneous hair, regardless of where, I mean, it shows up pretty strange. CT is what you usually confirm it with. And I say, using water-soluble contrast. I think a lot of times we still just use IV contrast. You can try to get them swollen. The problem is if it's traumatic, you don't know how bad it is. So regular CTs, I think, but the board exam will probably be using water-soluble contrast. But and these people are usually pretty sick, so treatment is resuscitation. You want antibiotics because obviously you got a mixing of GI bacterial into non-GI areas. Surgical repair is the only way to really take care of it there. So. Iatrogenic, Boerhaave syndrome, trauma, foreign body, all those can definitely cause it there. And it's pretty sick. People get sick pretty quick. Looks like that's ARDS on the top right there. All right, so pneumonia. Everybody's heard about pneumonia. There's a lot of people talking about pneumonia. I don't know what I'm talking about, but infection of the gas exchange portions of the lung. It's more periphery than central. Now, typically it's history, fever, chills, cough, sputum production, rigor, dyspnea, clinical exam. You got hypoxia, tachycardia, tachypnea, abnormal lung exam. All right, so when someone, that's a side note, so when someone's sick and they walk in, what's the first abnormal vital sign you typically going to see? Particularly with pneumonia. So you got some guy terrible pneumonia or whatever. Let's say if you were watching him 24/7 on a monitor at home for the last 3 or 4 days when he started to get sick, what do you think is the first abnormal?
Oxygen.
SATs?
Fever?
Respiration rate, no. Always the heart rate, always. Tachycardia is by far the most common abnormal vital sign, and it's always the tip of the iceberg of something wrong. Never send somebody home with tachycardia, period. Unless you know for sure, like, you know that they're on meth, okay, fine. Or if, I know, do a lot of that. So tachycardia, evaluating that. So what are the most common causes of tachycardia? It's a side note, but something you have to know and understand this, because otherwise people will roll over it. So,
Dehydration?
yes. What are the most common causes of tachycardia? So our fever, dehydration, okay? And I mean, I guess, because it's usually a secondary stress, an infection will trigger something, but yeah, okay. But main one of those thinking of, so fever kind of falls in that infectious process too. So fever, dehydration, two big ones.
Hypoglycemia?
No? Huh? Hypotension, well, I mean dehydration, typically. And you have ability to compensate, right? So the tachycardia is the first compensatory drive of the body. Every time, your blood pressure goes down, what's going to happen? The heart is going to go up to compensate for it, right? So that's kind of the first thing. So the two biggies, though, what are the two common things that people come to the ER for?
Shortness of breath?
Correct, but but for tachycardia, though, like
Pain?
pain, yes, pain, and pain. And then there's another one too, that's a little less obvious, but there's a lot too.
Stress?
Stress, anxiety, yep. Yeah, so those are the ones you gotta, so when I have a patient that comes in as tachycardic, I think to myself, what's triggering all this? Are they febrile? Are they dehydrated? Are they anxious? Are they in pain? Or is there a primary cardiac problem here? Because if they're having an MI, if they're having a PE, if they're having some of these different things, the first trigger of the body is to start having tachycardia. Just like nausea and vomiting is a standard response to the body too. Anytime you have something acute stress to the body, people get nauseous and they throw up. You get a kidney stone, they start throwing up because it hurts. They have a stroke, they throw up because their body's going into shock. I mean, it's weird. Like a nausea, vomiting, people think, oh, you must have a GI bug. No. And I always say, well, how are you feeling this morning when you got up? Well, I was fine, breakfast and this and that. Okay, all right, fine, all right. Well, they don't have the flu. So they're throwing their tailnails up because they got a 7mm stone that just fell out in the middle of the day. I mean, that happens. So you can't fall into that, oh, they're throwing up. Well, what's could be wrong with their tummy? Nothing's wrong with it. And like vertigo, everything makes them, throw up. So vomiting, just look at that as a stress response. Tachycardia, vomiting, those sorts of things, nausea even. I mean, I've had lots of heart attacks that come in with a little bit of nausea. That's it, no other symptoms. I'm here just because I'm nauseous. Oh, okay. Or a small bowel obstruction, I'm nauseous. Are you eating? Yeah, I'm eating. Liar, you're not eating. They just tell you they are. But anyway, so, sorry to get distracted with that. So the pneumonia, so tachycardia, and oxygen saturations will go down, but it's a late finding. Just like with PE, you don't rely on PE, on your oxygen saturations to diagnose a PE. If you do, they're dead. Because, I mean, we get PEs all the time. We'll talk about PE later. I'll go back to that one. So, all right, so tachycardia, tachypnea, abnormal lung exam. It could be subtle, it could be obvious. I mean, I can sit across the room and hear someone with pneumonia. Usually larger airways are much more phonic, so you can hear stuff better. Traditional pneumonia is going to be a decreased lung sound. A lot of people worry about hearing stuff in the lungs. I agree, it's worrisome when you do hear something, but I'm more over the side of I worry when I don't hear anything. Because if I don't hear anything, you're not moving air. That's my worry. Like if you got a bad asthmatic comes in, I'm worried about them because they're going, that's worse than going, because I can tell they're moving air. If they're gulping for air and they can't get in and out, I'm worried about that. So abnormal lung exam is going to be decreased lung sounds typically. Because if you lose the ability to perfuse because of the space is full of fluid or infection, you're not going to hear anything. Chest x-ray with infiltrate is confirmatory, correct. What's the delay though? Let's say someone comes in with pneumonia and you do an x-ray. Well, let's say, does it always show pneumonia if there's a pneumonia with a chest x-ray? No. How long would, let's say
A week?
I stab myself with a pneumonia pen and give myself pneumonia right now, boom. How long is it going to take for that pneumonia typically to show up on x-ray? Not 10 days, that's a little long. Maybe I'm overemphasizing this a little too much. Typically 24 to 48 hours even. Depends on a couple factors though. How sick are they? And hydration status plays a huge part. If they're dry, you won't see anything. Because if you think about an x-ray, x-rays only reflect what's there. So if you're dry, you're not going to create much mucus, much fluid, it's not going to be in there to see. And what's funny thing happens with pneumonia patients, they seem to get a hell of a lot worse on x-ray, even though they're feeling better in the hospital, when you admit them. Because you admit them, you give them a little bit of IV fluids because they haven't been feeling so good, and you give them antibiotics, and they go, gosh, I feel so much better. You look at the x-ray and go, you're going to die. Your x-ray was terrible. What's happened was it was always there, but you just couldn't see it because it didn't fluff out, right? So that's why x-rays are great and all, but don't hang your hat on x-ray. You can clinically diagnose somebody with pneumonia long before you see it on x-ray. Don't be fooled. If they're febrile and they're congested and you think they're wheezing or they're coughing a bunch or something, they've got pneumonia. If the x-ray looks okay, screw the x-ray. Get a CAT scan if you really want to confirm it with imaging. So, treatment, oxygen, blood, and sputum cultures. Sputum cultures, they're hard to do. No one really does them very much anymore. Even blood cultures, it's more of just like a standardization thing. But you can do it. If they're really sick, it can come back to be helpful. But everybody wants to start blood cultures. If you're going to put them on antibiotics, if you need IV antibiotics, then you typically want to do blood cultures first, which is kind of standard of care if you're going to put them in the hospital. But if you're sending people out to the clinic, you're not doing blood cultures where you send them home with a Z-Pack, right? I mean, it's not going to help. So, and then bronchodilators. Bronchodilators, there's a lot of studies in this. Some people think it's okay. I think it's only really helpful if you have underlying lung illness. And then if you do, you want to treat it also. So if you got COPD, people with pneumonia with COPD tend to do better. We'll do better with steroids in association with the antibiotics, not just taking antibiotics. So you have to look at the whole picture. So they've got asthma, put them on the bronchodilators, because any kind of acute stress response will exacerbate their other underlying lung pathology. So they've got asthma, they've got COPD, give them steroids in addition to the antibiotics typically is what we find that does better. So, because it's going to exacerbate their clinical stuff. So here's some pneumonia. Now, they're going to be broken down birth to 1 month, 1 to 3 months, 4 to 5 years. All that just because you need to know what kind of bugs are more common. And that'll be all in your exam. And whatever I say today, you're going to forget anyway, so it's no big deal. But just know that, like, different age groups have different bug risks. And it may all be the same, whether it's a community, which is a hospital, and you're always going to look it up, and the recommendations are going to change. By the time you guys are out of school, there's going to be a whole other bunch of recommendations for ages and stuff. So just study what you need to know for your boards, and then when you get out, look at, and there's a bacteriogram. You guys know what that is? Every facility has it. So basically they have the lab publishes their information on what kind of cultures they get. So they'll have patients that, let's say UTIs are classic, so they'll have UTIs and say, this percentage got better on, okay, they'll have a list. This percentage were resistant to Bactrim, to Keflex, to Macrobid, and all these different things. And so some places, like I remember I worked in Lawton, and they had like a 60% success rate with Bactrim. So basically you just don't get Bactrim for UTIs because it's not going to be better. Whereas other places I've worked, it's been like 90%. So if you want to try that, you can. So every place has their own bacteriogram. So look into that because they publish it every year. And it gives you a better idea of what's in the community because it tends to kind of run streaks. So pneumonias are that way. And this is a clinical test, so it's more accurate than what the patients just tell you they got better. All right, so PE. This is the big one that everybody's super excited about all the time. Results when the proximal portion of a venous clot is dislodged, travels through the veins to the right ventricle, and becomes lodged in the pulmonary arteries. So typically leg to a lung. Often difficult, easily missed, have a high clinical suspicion based on risk factors. The D-dimer for screening, confirmed with a CT arteriogram or a ventilation perfusion scan or angiography is the best gold standard. So the guy that invented the D-dimer, he's been quoted as saying he wished he never invented it. Because the D-dimer has basically increased the number of CAT scans 1,000-fold. And so a D-dimer, you guys familiar with what a D-dimer is? So a D-dimer is basically it's a measurement of breakdown in clot products, right? So it's great. If you have a clot, it's going to be high. Problem is, if you have had Chinese food last night, it may also be high. Because everything seems to make a D-dimer go up. pregnancy and recent surgery and sitting around on your butt too long. And, I mean, it's crazy. And then you get into the question is, it's not a positive or negative test, it's a measured quantitative test. So the typical high, depending on where you work, 400 to 600 usually. My shop is 400, which makes it kind of tough. So there's some studies that say you can use 10 times the patient's age, which will help you a little bit. Because if you've got a, let's say you got a regular high of 60 or 600, and the patient's, 82, and the D-dimer comes back 650, well, technically their high is going to be, what is that, 82, 820, right? So you're under their cutoff. Traditionally, if you've got a big clot, it's going to be in the thousands, and you're going to know it. Now, there are some screening recommendations for low-risk patients. I will use a D-dimer on a low-risk patient because it means I did something. If I have some patient that comes in and says, yeah, my leg's kind of hurting, it's bigger than it was yesterday, and I don't want to go to work today, and they're here for a work note, you go, well, okay, let's do a D-dimer. Oh, guess what, great news, it was, 100, you can go home. So I will use it for ultra low risk, but basically, if you think that there's someone who has a high risk factor for a PE, you gotta scan them. And CT has really kind of become the standard because it's fast. It's more radiation than a ventilation perfusion scan, but it's better, it's faster, it's more usable, and we can do it like right now. The VP perfusion, I don't know if you guys seen that or not, but it's really weird. They have them like breathe this radioactive stuff and they blow it out and they take pictures before and after and they try to see if there's a filling deficit and blah, blah, blah. It's hard to do that test. They gotta order the stuff and they gotta get it ready. And so it just takes a long time to get that coordinated. Now sometimes you're stuck doing it, but most of the time it's all gonna be CT scan. Even pregnancy now, I notice a lot of OB-GYNs that don't mess around with the ventilation perfusion. If you've got a pregnant lady who has significant shortness of breath, then use a scanner. And it sounds kind of crazy, but I know some of the recommendations may not be there yet, but that's what they're doing in real life. But you always want to try to start with D-dimer for low risk, but the problem is if you've got someone who's in a plane or somebody who had surgery a week ago, what's the likelihood of D-dimer being negative? Almost zero. So you're completely wasting your time for a 40-minute test to come back positive that you already know is positive. We don't screw around. The thing about PEs that are interesting is, everyone's had PEs forever. It's just now we're like super sensitive about them because we can look for them. I mean, even just 50 years ago, we probably had the same PE rate, maybe higher, I don't know. But we didn't have a way of looking for them, so we just kind of went on. There's people in this room right now probably have a PE, you just don't know it. People have PEs all the time. A small clot breaks loose, gets in the lung, body dissolves it, goes away. But is there enough PEs at one time to become symptomatic? That's the question. Or is there some underlying illness that's increasing your likelihood of having a life-threatening PE? A big saddle emboli, a big multi-clot formation. I mean, are you hypercoagulable? Are you sick with cancer? I mean, is there something else going on that put you at risk? So oxygen saturation is always going to be the last thing that drops with these people too. First thing is always tachycardia. So that's why it's like, don't send home somebody who's tachy. Please don't. And if you think they're tachy because they have a fever, we'll give them some medicine and get the temp down. And if they're not tachy anymore, fine. But if they've got a big PE and they're febrile because they have a pneumonia or some other problem, get their temp down. And if the temp comes down, they're still tachy. That wasn't the reason. So any kind of acute stress will cause the heart rate to climb. You treat with anticoagulations, thrombolytics. Clot retrieval can be done in very large clots, but it's pretty rare. All right, PE. So who gets PEs? Typical pregnancy, hormones, trauma, cancer, plane rides. Anytime someone's sitting around or hypocoagulable state, you pretty much get it. So you can see some on x-ray if they're big, like this x-ray on the far left here. That's a pretty big wedge infarct there, so I mean, it's pretty obvious, but terrible x-ray. The bottom right, yeah, you think something's wrong with that guy? So, yeah. All right, so let's talk about pneumothorax. I saw one of these Saturday. Pneumo occurs when air enters the potential space between the parietal and visceral pleura. A lot of these acute illness stuff is going to come down to knowing your anatomy. Understanding your anatomy will help you to kind of like realize like what's going on and why people have some of the symptoms that they do. So it's pretty straightforward from a standpoint of, and I'm going to go through this because there will be someone in this class that will benefit from this. I don't know, maybe more than one. Some of you will go, oh, that's so dumb, I know exactly. So they used to talk about the lung as a box kind of a thing. And so then you get your lungs in here. And then connects to the pipe that goes up the top. So, all right, so your diaphragm is what you need to really understand. So this is a closed space, it's all about pressure, right? Your diaphragm goes down, increases the space, therefore decreasing the pressure here. A lower pressure outside in this space then allows the lungs to expand and be drawn out. The lungs expanding and being drawn out is what sucks air in from the outside. You don't push air in your lungs. People think it's, no, you suck air into your lungs. It's a weird phenomenon. You don't think about it right now, everybody's doing it. Okay? So anything that affects this very precarious vacuum system will mess it up. Now luckily, there's a pretty heavy mediastinum, right? And so you have kind of an isolation between right versus left, which is great, because then if you drop a lung, you can still be just fine. And the other day I had a tall 27-year-old guy come in who had a complete pneumo on the right. And his stats were 98%. Heart rate was like 96. He was a pretty conditioned athlete. His normal heart rate was about 50. So he was stressed. He wasn't over 100. That's another thing, like relative tachycardia, right? So over 100 screams at everybody, you know, it flashes your EMR saying something's abnormal. But if you got somebody who's like a conditioned athlete that's in great shape all the time, and now so their heart rate's like 97, and that little thing's not flashing, it's like, wait a minute. So anywho, let's say, what's the most common cause of pneumothorax?
Spontaneous.
Okay, spontaneous. Okay, but from what? Spontaneous. That's just kind of like saying car accidents or because there's accidents. Like what spontaneously happens? Spontaneous. So the most common ones that you'll see, there's two categories really. For some instance, I'm not really sure why, young, tall, thin males get spontaneous pneumothorax. It's a weird phenomenon, I see it all the time. But the other one are going to be your COPD smokers, and the theory on that is COPD, your lungs are crap, and so you get like this thinning effect. Instead of the alveoli being like this, one alveoli goes and just like pops out really thin, and it stretches. You know how things are when they get stretched like a balloon. Stretch, it gets thin and then more likely to pop. So that's what's going to happen on some of this. So sometimes you can have no trauma, but an old COPD lady driving with a seatbelt is your worst possible scenario, because it's either going to be a pneumo or a dissection or something else. But so yeah, so spontaneous. Trauma is pretty easy, right? I mean, you got a knife that comes in here and cuts this. Then if you've got like a continued open versus not, I mean, there's different things you can actually, do they cut the lung all the way, the laceration where it just collapses. So I think that understanding the physiology here really well will help you to understand, like, when you go to evaluate a patient, what all could be going on. Also, overventilation. Little kids, you put too much air in, you spread them up, you can pop them yourself by overventilating, particularly newborns. Happens all the time. So how does a tension pneumo happen? You guys know that? So from a physiologic standpoint, so what happens is this lung will collapse. Let's say you get a knife stab right here. So it cuts the lung a little bit. Well, it's going to collapse. So then you've got your lung that will partially, collapse. It's still got that hole in it. So you're taking a deep breath, you're decreasing your pressure, and you're sucking on this, and air is leaking out to here. And so what's happening is every time you take a breath, more air gets out, more air gets out. And so then it's putting more and more pressure on this. And then it gets to a point where it starts putting pressure on this side, and that's when you start to get your shift. Of course, your heart's sitting right here. And so as you start to get your shift, you do a couple things. You start putting pressure on the inferior vena cava is bringing blood back to the heart, and it starts putting pressure on that. And then it's got putting pressure on your airways, it's putting pressure on the aorta, everything. And so, that's why the tension ones are so worrisome. They always talk about how you never diagnose tension pneumothorax on x-ray. Well, everybody does, because you walk in and some person's like, I can't breathe, and you look at their stats, and if they're not like, 10%, they're probably okay for the moment, and then you do an x-ray and go, damn, I got a big tension pneumothorax, I better go do something about that. So, let's see, diagnosis, suspect based on history and physical exam, diagnosed with chest x-ray, except tension. Yeah, well, they say that, but everybody says tension. You're supposed to catch it, but if you listen to them, you don't hear lung sounds, then you're like, oh gee, maybe it is a tension. But if they're trauma and all this stuff, the problem is people are hesitant, how you fix a tension pneumothorax? There's two things you do. First thing is
Relieve the pressure.
needle. Yeah, what do you do about, how do you put the needle in?
Let the air out.
Let the air out. Correct. Where do you put it in? Yeah, so you stick them, right? Because the idea is it's supposed to be above the lung, right? So you don't try to decrease as much as possible. Well, I've had people who have caused pneumos. A lot of EMS guys are a little excited and they think they don't hear anything and then they boom. And then they really watch their stats deteriorate. Because then it's like, oh crap. Because you stick a needle in here, boom, and you hit the lung, then you drop it some, and it makes it a lot worse. So yeah, so first thing is you stick this in your atmosphere, quick, fix it, and then you can stick and put a chest tube in the same side and reinflate that way. So that typically is how that's fixed. So oxygen needle decompression, thoracostomy tube, and that's for the treatment for pneumo. Now here's the trick. I had a guy just the other day. How do you diagnose a pneumothorax? Chest x-ray? Okay. So what do you look for on a chest x-ray? Now, this is something that no one really explained to me a whole lot, but I kind of picked up on it after a little while. So here's your chest. You can't really see the heart border part because it kind of messes you up here, right? So how do you know if this is collapsed or not? You're going to see shadow lines. You're going to see the most common thing is your scapula is going to look kind of funny coming through here. And people a lot of times will think that's a pneumo because they think the lung's laying like this. In reality, they're just getting too much shadow from the scapula coming through in the back of the lung. So that's the most common thing. So you look at your, I can't really play with this very much, like I would be able to. You can't really see scapula very well in these x-rays. Yeah, you can kind of see a little bit over here, maybe. But here you can actually see the pneumo here, the line drop. But it's hard to tell subtle pneumothorax. And what you have to look very close for, and it's hard to tell in these pictures here, is lung markings. On a good lung, you're going to see these little kind of squiggly lung marking lines. You're going to see them go all the way out to the edge. Okay? It's important to follow those all out because on where the pneumo's at, they are missing. So I mean that's like one of your telltale signs. But do not be deceived because if you look at the CAT scan picture, I had this just the other day. So if you've got your lungs like this, your lung cavity, yeah, not ours, lung cavity. I had a guy that had a 30% pneumo, and his X-ray looked perfect. I mean, he had lung field perfect. I mean, everything was good. And the reason why is because the lung was collapsed in a way where it was like this. And so all of this was collapsed. But when you look at it from the front with an X-ray, this is the top, this is his head right here. Okay. If you look at it, you can kind of see it on this here. See how this lung is kind of flared out here, like this? If you look at an X-ray from the front, when it goes straight across here, you're going to catch the lung. This one's a little bit shallow. But for instance, let's say this little tail was a little bit over, a little bit more, maybe up against the wall here. You can see how taking a picture from the front, you're going to see lung fields all the way up to the edge. This happens all the time. So if you still have a high suspicion someone has severe respiratory distress, do a CAT scan because you'll see it like this. Now sometimes you can see it from a lateral, but the lateral, the other lung screws you up because look, this lung is fine. It's going to go all the way back. There are some funny angles like old school they used to do with X-rays before CAT scans were around. They kind of do like a rotational chest type deal. but they don't really do that anymore, it's just CT. So just know that like, when you're looking at somebody, if you see lung fields all over, don't say, oh, they can have a pneumo. Heck yeah, they can have a pneumo. I mean, chest x-rays are very deceiving for a lot of stuff. Fluid, infection, all sorts of terrible stuff can be there, you just can't see it. But a classic pneumo you will see on an x-ray. So, also what you'll see too is, they call it like a large, like deep sulcus sign. And you'll see it in here too because, so for instance, like we were talking here, how this is collapsed. So as the pressure goes up, two things happen. So you get your diaphragm, it sits like this normally, right? So, diaphragm sits kind of like this. Okay? Now, you take a breath, it's going to go down. And so, if you do that and this pressure keeps pouring out of this lung, this pressure is going to go up. What's going to happen is it's going to push on this whole entire chest evenly, typically, more on one side first. It'll push on this one, and then you'll start to see this pressure push down, and then you'll get this deeper, like sulcus sign down here. See how that kind of drops down right there, real sharp on one side, and the other side is way up here? That's one other thing you can see with a pneumo, is the air gets back there and pushes that diaphragm down and starts to increase the pressure, but only when the pressure goes up. So understanding the physiology on that part. You can see a real deep one over here. Look how deep that one goes, all the way down. And know this too, all x-ray techs that know their business will repeat the x-ray if they cut off the bottom of the lung fields, and that's the reason why they do it. You'll get somebody like old smoker, old COPDer that'll come in and they'll have to take the x-rays a couple times because they'll be so tall they can't get them on one plate. So tall skinny guys smoke for 60 years, they'll have a couple of films you need to look at. And the bottom films are just really to look at those, make sure that they come down to a point. Make sure there's no blunting. You know, if you got fluid in there, it's going to kind of disappear. All right, conclusion. How are we doing on time? Okay. Chest pain is common. Everyone, what's the most common complaint in the ER?
Pain.
Primary complaint. They go, what are you here for? I'm here because it's abdominal thing. 40% abdominal. But chest pain's up there. I think it's like 25-30%. So it's up there too. Headaches about 5%. But, you know, everything you think we see a lot of. But so take chest pain serious, or secure a safety net, thorough history of physical, 7 deadly, MI dissection, tamponade, esophageal rupture, pneumonia, PE. All right, questions or comments?
With your tension pneumos, do you almost always have subcutaneous emphysema or no?
No. Not till I
Only
find
with
it.
trauma?
Yeah, trauma, because you have to have a pretty substantial perk through the chest wall in order to get subcutaneous, because otherwise it doesn't track there. You have a question?
Yeah, can you go back to slide 10 and point out on the EKG where you're seeing the acute MI?
Sure.
So what are you looking for an acute MI? What indicates MI?
All right, so here it's 2,3 AVF. So how do you know how do you measure your ST, right? This is a big problem. Not every EKG is going to be pretty. I can't tell you how many EKGs. Every day I get EKGs like this. I mean, you're like, where the heck? Where is my baseline? I mean, you're just like scratching your head, cussing at the tech. You know, you just go, you're not helping me here. So your P, then you got QRS, and you get your T, right? This is the key, QRST, so ST elevation. So this line right here, I don't have an underline, but this line right here is what you're looking at. But you're looking at it as comparison to your baseline here, okay, or here. That's what's hard. So when you look at this part here, let's see. So, can you guys see my pointer? All right, so right here, this is what I'm basing it off of. The ST is this from right here, this little plateau, this picture, compared to before and after. Look down here, it's down here, and up here, it's down here also. See? So this is a nice EKG. It's like right on that line. And so it's showing it is elevated right here. And look right here, it's just subtly elevated over here. Right? And we can talk a ton about EKGs. I know that they teach you EKG a certain way, but it's a whole bunch of old garbage. Because in the end, like I look at probably, most EKGs I look at and interpret in about 30 seconds. I can just look at it and go, sometimes I'll go, holy damn, what, you know, and then you have to like, but most of the time you're like, eh, or maybe, or, you know, or repeat it, or hey, let's do a posterior or whatever, so you get used to it, but like, left side of deviation, and then hogwash. Never ever had anyone die from acute left side of deviation. It's like, never, like, they would laugh you off the phone, you called the cardiologist, oh, yeah, sounds good, okay, left side of deviation. I don't think it's gonna make it. So, yeah, I don't, it's a goal, so.
I used to, when I very first started, if I was having a hard time seeing it, literally take a pin with their straight edge and follow your baseline from the beginning to the other baseline and draw a line and see if that STA wave is below or above that line. Just connecting your baseline before and after helps you to really visualize that. It's really subtle.
Yeah, and you don't need calipers, unless you're a cardiologist and you really need to carry around like fancy. You know, I know cardiologists don't use their own damn calipers, so they just use a piece of paper. It's so easy. I don't know what paper this is. But, alright, so I use paper all the time. So let me just show you. This is like best thing in the world. So you got your PQRS, then you got your PQRS like that, right? So what you do, you hold a piece of paper and you go, okay, Mark, Ruh-roh, I'm telling you, every time, because you have a fast rhythm, you can't tell, or really slow, you can't tell. That is it, that's, and then you can take this, and you can copy, you can do this all over the place and look and see, you know? You'll be able to tell, you know, like, oh wait, no, that's not right, you know? So, that's all you need to know. Don't worry about all this calculus stuff. A piece of paper is worth its weight in gold on this kind of thing. And some people will take the EKG and like fold it up. I don't do that. I just take another piece of paper because that way I can move it around. That way you can pace it out and see if it's really off or not. So then we've got the reciprocal changes here too. So you got V5, V6. See how that ST is depressed? So the classic MI is going to be ST elevation somewhere, and then it's going to be depressed somewhere else. So, which is helpful. But then again, there's going to be one particular heart attack. What happens if you have all ST depression? Uncontrolled depression. Like, what does that? You have that? So it's stress on the heart, right? But there's one caveat. Whenever I see that you've got a bunch of depressions that are pretty significant, I will tell the tech or the nurse to do a posterior MI, or posterior EKG. And what that is that takes the last two leads, the V5, V6, and just puts them on the back, right below the scapula. Because guess what? All of a sudden you're going to repeat it, and that V5, V6 is not going to be depressed, where it's going to be elevated, and guess what? You have a posterior MI. So that's one trick, not to screw up there, but and then you've also got like, I'm going along, but there's some basic things about EKG that make your life so much easier. Just like that. I mean, I was in the changing of the guard in med school. There were several old cardiologists going out, some new ones coming in. Oh my Lord, I about hung myself in a closet when we had the old guy going out trying to give you. I mean, I literally, it was like 2 months, twice a week, or 3 times a week, listening to this old guy talking to EKGs. I could not keep my eyes open. For $1 million, I couldn't tell you what the guy told me every day. It was so boring. He was just like, okay, when he starts with the physics lecture, okay, now here is the arc of the electrons, and you've got negative and positive. I'm out. And there's no way. Where's the heart physics? So, then you got, so you guys heard like benign early repole? So you've got your P, and then you got your, QRS, and then T wave like that, right? So there's your classic ST elevation. Okay, well, sometimes this is not so clear as this. Sometimes this morphs into something a little bit not so clear. So for instance, the QRS is like this, it kind of comes up, comes down, and then it kind of morphs into this wide something, right? And then it kind of goes back or something, right? Now you're starting to get that tombstone, right? Everyone knows about the tombstone, okay?